Good afternoon, everyone. My name is Anushri Ganguly. I am the Champion Support Manager for the network. This is our second Lunch and Learn webinar, and we do intend to continue with the series on a quarterly basis. As you can see on the screen, this is our session overview. I will take you through the research roundup. I can see some more people joining. Just bear with me 1 minute, and I will let them in as well. Okay, so the research roundup is all the key events and webinars that are coming up in the near future. We have the Scottish Preconception Network Showcase face-to-face event planned in Stirling on 26th of March. We have the 11th Annual Research Conference on the 14th and 15th of May in RGU. Grampian. We have the ATTC network who are hosting the webinar on the 9th of December, and all this information will be shared to you in an email as well as the newsletter for the network as well. We also have the Patient Public Involvement PPI event coming up on the Tuesday, 3rd of March in Stirling. We then have the Health of Women Research Network. They're asking for everybody to register interest. And our next Lunch and Learn webinar dates are on the screen as well, 18th of February and 17th of June. If you'd like to contribute in any way, present, talk, or chair, please do get in touch with me. And as I said, I will share all the details via the newsletter and via other communication channels as well. So with this, I take the opportunity to introduce our chair for today, Dr. Lucky Saraswat, who is going to introduce our speakers. And let me I'm still admitting more people who are coming. Dr. Saraswat is a consultant gynecologist and minimal access surgeon in Aberdeen Royal Infirmary since 2014. She's also the lead for the Aberdeen Endometriosis Centre. She has, prior to taking up her consultant post, she completed her specialist training in obstetrics and gynecology in Aberdeen and was awarded the gold medal RCOG in 2005. She went on to do the prestigious RCOG Advanced Laparoscopic Fellowship and undertakes complex surgeries. She has a keen interest in women's health and research, and many of you would know her from before as well. And with this, I will give the mic to Dr. Lucky Saraswat, and you're welcome on the screen.
Thank you, Annie, and thank you for inviting me to chair this webinar. So I think it's a great series that has been started. Before I introduce Neil, I wanted to make sure he's here. He's here.
Hello. Sorry, apologies.
Here. Okay, because I wasn't sure. So our first speaker today is Dr. Neil Ryan. He is an oncology subspec trainee in Royal Infirmary of Edinburgh. He's also a CSO and NES lecturer at the University of Edinburgh. Neil completed his PhD as an MRC Clinical Research Fellow at the University of Manchester, where his work led to change in NICE guidelines on endometrial cancer testing. His research focuses on molecular determinants of cancer risk and treatment response, with a particular interest in mismatch repair deficiency, which is what he's going to talk about today as well. He also leads the EU PREDI-Lynch Gynaecology arm and is developing translational trials to improve personalized care in endometrial cancer and other gynae cancers. And this is really worthwhile given the incidence of endometrial cancer is rising. So I would like to invite Neil to give his talk on and he's going to talk about mismatch in testing in endometrial cancer and Lynch syndrome diagnosis. Over to you, Neil.
Thank you so much for this opportunity to talk, and I'm sorry that I'm in pajamas. I'm in theatre today as well. So those are my honoraria. I sometimes get paid a little bit of money from GSK to talk. What I'd like to give a sort of an overview is what we're talking about, mismatch repair deficiency in this talk really is using it as a way to screen endometrial cancers for Lynch syndrome, because I think that's the thing that we are doing badly on the gynecology side. You know, the pathologists are doing all this testing. We're not really following up as well as we should do with our Lynch syndrome testing. So with that in mind, just something to clarify, because I always find this confusing myself. When we talk about mutations, there are mutations which are germline, and those mutations obviously are inherited. They're things that people get from their parents, and every cell in their body has that mutation. It's something that started very much within the gametes. And that's what Lynch syndrome is. And then when we talk about mismatch repair deficiency, that can be a somatic mutation. And what that means is it has just occurred in the cancer or a cell line of the cancer. So the individual doesn't have Lynch syndrome, but the tumor has Lynch syndrome, if you want to think of it in that way. And so I'll try and be really clear about which mismatch repair deficiency I'm talking about as we move forward. One thing just to also be aware of, obviously, is what are the principles of screening? Well, the principles of screening are that we actually diagnose people before they have the disease. So talking about screening in a population with cancer feels a bit wrong because they have cancer. So we have actually missed the opportunity to screen that population because they have the phenotype, they have the disease. But because we identify somebody with Lynch syndrome and they may have relatives and we can test those relatives, what we actually are doing is we're screening their relatives because hopefully their relatives haven't developed a cancer. And that means that we can get in there early and intervene and reduce the risk of them getting cancer. And that's how this screening works in this model. This is a learned audience. I don't think I need to go into too much detail about endometrial cancer, but just to say that we know it's on the rise. It's been described as an epidemic. So the other thing just to be really aware of as well is endometrial cancer is often just thought of as a cancer that's, well, who cares? You know, you diagnose it at stage 1, they do really well, they have a hysterectomy, that's the end of the story. Well, if we think about cancers that are on the more advanced spectrum, so stage 3, 4 endometrial cancers, they behave extremely poorly. And they are, unfortunately, as lethal, if not more lethal than ovarian cancers. So there's a real need to detect these cancers early. And again, in a population with Lynch, where they are very high risk, but they are difficult to diagnose because they're young, sadly, they often, well, not often, but they can present with advanced disease. So this is why it's really important that we're identifying those with Lynch syndrome, because an endometrial cancer isn't a benign disease, especially when it's advanced. And obviously, these people are at risk of other cancers, such as colorectal cancer as well. And they tend to die now, actually, not from colorectal cancer, but from uroepithelial cancers and also gynecological cancers. So it's really important that we're doing our job as well. This is something that, you know, we all are familiar with, I hope. It's the 4 molecular groups of endometrial cancer. It comes from the Nature paper in 2014, wasn't it? Which came through and sort of said, look, we've got 4 molecular groups in endometrial cancer, and those molecular groups act very differently. So if you look at the survival, this is a Kaplan-Meier graph over here, months, so time along the bottom, percentage of people with progression-free survival along here. And the different molecular groups map beautifully into... the phone ringing, I do apologize. And they map beautifully into the 4 different groups, 4 different survival characteristics. So your poly ultra mutated survive very well. This is your mismatch repair deficient here, where you've got a improved survival when compared to the P53 mutant. And then you've got this non-specific molecular group in the middle here. But this is the group that we're going to be interested in, this mismatch repair group. So we do see increased survivability, but as you can see, as we go further into time, they still are not surviving, you know, at a rate that's different to the non-molecular group. So we just need to be a bit mindful, because again, people say mismatch repair deficiency, oh, you've survived your endometrial cancers, they're very benign, and that isn't actually what the data tells us. We do see something very interesting with mismatch repair deficient cancers, which is outside of Lynch syndrome. They actually can be a group that are exquisitely sensitive to immunotherapy. So why is that? It's because these cancers are constantly making mutations. Those mutations are turning into proteins. Those proteins look unusual, and they stimulate the immune system. So there's 2 reasons to test for mismatch repair deficiency in endometrial cancer: finding Lynch, which is the focus of this talk, but also to identify those women who are going to really benefit from immunotherapy, because we know that this group is exquisitely sensitive to it, and around 40% of them will have a really meaningful clinical response. This stuff has started to translate into our clinical work. So we're seeing in PORTEC, which is a study looking at adjuvant radiotherapy, that we are beginning to see the different molecular groups behave in different ways. And we are now starting to see that the PORTEC classification, the TCGA classification, all these classifications are starting to filter through into our clinical practice. And so the PROMISE algorithm is what most of us now use across the United Kingdom to decide which of our endometrial cancers are into which molecular group. There is a stepwise testing pattern, and we can see that all cancers really should have MMR testing. And that is something that NICE strongly recommends, as well as also Scottish guidance. That is because this maps on to survivability, but also it identifies this group, this mismatch repair deficient group, that we know we need to do extra testing in. And this is a very confusing slide. It's a bit like being lost in a maze, but this is actually what happens when you put all of the molecular stuff together with the current clinical guidance from ESGO and BGCS. And you can see that you could start off with a stage 1 with no LVSI, which is low grade, and that would basically mean that we can do quite limited surgery and no adjuvant therapy. And then we get to the more sort of terrifying disease where even though it's stage 1, it has a P53 mutation, and that means that we need to be thinking about adjuvant therapy. So all of these things are starting to fit in, they're all starting to come together, and they're beginning to impact on our clinical practice. So testing for mismatch repair deficiency isn't just about Lynch syndrome, it does define how we treat these tumours. And that has now been adopted controversially by FIGO in its staging classification. And I'm not going to go into too much detail about this, because FIGO is something that many pathologists aren't in agreement with. But just to say, this testing is not just about Lynch, it's part of our clinical makeup now, and it's something that we must be doing. Okay, so I just wanted to mention as well that there's a little bit of discussion around this POLE group, which again is slightly outside of the topic of this talk, but everyone goes, POLE? Oh, they're nothing to worry about. Everyone survives. Don't worry about POLE. They're really benign. Actually, there's data coming through now to suggest that they do recur and they can actually be quite aggressive. So we just need to be careful, because if we start de-escalating treatment without evidence, then that makes me feel a bit anxious. And remember that all of these studies that have gone before that people cite, in those endometrial cancers, people received the standard treatment. We didn't change their treatment on molecular grouping. So it's really important to be aware of that. Also, just to say that the cancers that are mismatch repair deficient, they are not themselves all the same group. They're a heterogeneous group. And what I mean by that is that their molecular profile is determined by either having Lynch or by having a somatic event, the tumor having Lynch syndrome. And that changes what cells we see within the cancer, specifically immune cells. And that changes actually their prognosis and their response to immunotherapy. Okay. So let's talk about Lynch syndrome then. So Lynch syndrome is an autosomal dominant disease. It's inherited in a 50-50 chance from your parents. So if your parent has it, you have a 50% chance of having it yourself. Lynch syndrome is extremely common for a genetic cancer predisposition. It affects 1 in 278 people, according to the Biobank, UK Biobank work that's done. Some people say 1 in 400 people, but it's still common. It's more common, or if not as common, as BRCA mutation. But many people are still not aware of it. And the people that aren't aware of it, and this is really important, are the people with Lynch syndrome, because 95% don't know they have Lynch syndrome, which is really terrifying. It's a disease that we've known about for some time. It was first described in the 1850s by Wartholin, the chap on the left. And then Lynch himself, Henry Lynch, picked up on the family that Wartholin had described and defined the condition more thoroughly. And his pedigree is up at the top there. And he thought that this was a condition very much of colorectal cancer. If you go back to Wartholin's pedigree down here, actually a lot of the women have endometrial cancer. And actually Wartholin first spoke to a woman who was terrified of getting an endometrial cancer. But we kind of forgot that because of the innate sexism within history and within science. And so the disease became very focused on colorectal cancer. The disease comes about because the mismatch repair system is faulty. It's faulty because of this inherited mutation. And that basically means that you get loads and loads and loads and loads of errors within your DNA, lots of spelling mistakes, which means that you eventually might knock out an important gene. And if one of those genes is an oncogene, then you are on your way to developing a cancer. That means, though, that these cancers have specific signs, telltale signs, little clues that something's going on. So the immunohistochemistry on the left shows that the protein, in this case MLH1, is missing. It's not staining, it's absent. Because you're getting all these spelling mistakes, those spelling mistakes tend to happen in little repeats of DNA called microsatellites. And this can be detected by MSI. So we can see there that there's these little wiggly lines where there shouldn't be extra wiggly lines. And we can also sequence the genes and say, look, here is a gene with a mutation. Now, we did a study back when I was doing my PhD back in 2019, looking at what would happen if we tested all endometrial cancers for mismatch repair deficiency, because back then that wasn't standard practice. It was starting to be adopted in very well-resourced hospitals in the United States, but not within the UK. And what we found was two things. One, that the incidence of Lynch syndrome in endometrial cancers is around 3%. So that is pretty high. It's the same as for colorectal cancer. And the other thing that was really interesting was that we thought up until this point that you could use immunohistochemistry or MSI to test for Lynch syndrome in endometrial cancer, but we actually found that the MSI didn't work very well. So this is an area under the curve. This is a rock. And what you can see is the immunohistochemistry up here is actually very sensitive, very specific, whereas the MSI, this red dotted line, isn't actually as well performing as we thought it would be. It should be up here with the IHC. And the reason for that is that the MSI testing was very much developed in colorectal cancer. So applying the molecular markers of colorectal cancer to endometrial cancer didn't work as well as we thought it might do. We published guidance, which is still out there, the Manchester guidelines on Lynch syndrome for gynecologists. And this really was written to be as straightforward as possible. We didn't want to overcomplicate things. And it's also something that patients were very heavily involved in. And there are sections in there that patients very much can refer to help guide their care. But what we're hoping is that this is a reference point for people managing those with Lynch syndrome for gynecological cancer. And it also has guidance in there about testing endometrial cancer for Lynch syndrome. How do we do that testing? Well, NICE has thankfully produced quite a straightforward flowchart for us to follow. We basically do immunohistochemistry because we know that's more accurate. If there is an MLH1 loss, then we need to think about reflex testing, which is through hypermethylation of the promoter region of the MLH1 gene. And that's the one that you just have to remember. MLH1 is the one you have to remember because it can be somatic. Very rarely that hypermethylation is actually inherited. It's constitutional. So even if you have someone with hypermethylation, but they're young or they have a strong family history, it's worthwhile thinking, should this person be referred to genetics? If they've got loss of MSH2, MSH6 or PMS2 that's isolated, they do need to have definitive germline testing for Lynch syndrome because Lynch syndrome is likely in that patient. Around 50% of them will have Lynch syndrome. Okay, how are we doing then with this testing? Well, we're not doing great, is the take home. So the pathologists are doing really, really, really well at testing the tumours. So 91% of the tumours are being tested. And this was between 2002 and 2023. So hopefully things are better now. But from our perspective as the gynecologist that should be making the referral, only half of the patients who needed to be referred on to clinical genetics were referred. And that means that we're only detecting 1% instead of the 3% that have Lynch syndrome. We're missing a significant proportion. And you can see here that actually reasons for referral to genetics are mixed and people are picking up on family history. But again, it's really important that we're not missing those that are identified through the tumour testing and we are following them up through the entire pathway. People often sort of say, well, what can we do about this? Well, actually, in England, there was a lot of discussion about this and there was centralised funding from NHS England to improve what was going on. They developed the GMSA, the Genomic Medical Service Alliance, which had a specifically funded project, which was the Lynch syndrome project. This publication discusses its construction. And what this meant was that every MDT had a Lynch champion who was responsible for making sure that any results from the tumour testing that looked very much like it was indicative of Lynch syndrome went on to have a referral to clinical genetics. Now, some people argue, well, why should this be the surgeon? This doesn't make sense. We are surgeons. We're not involved in genetic testing. Why should we be the ones doing it? Well, I think that that's wrong. We meet the patient right at the beginning. We take their family history. We do the biopsy often, and we have a central role in the MDT. And actually, these results come back to us as a clinician looking after the patient because often medical oncology or another physician isn't involved in their care. So we should be seeing the patients with the results, and we should be following them up and ensuring that referral is made. This is what people thought when we surveyed them. They thought, who should be the person responsible for doing the testing? You can see there that half of the MDT thought that the surgical team should be responsible, whereas what I thought was quite interesting, the surgeons themselves thought that they shouldn't be responsible. The majority of them thought it wasn't their problem at all. And that's why it's something that we need to be constantly thinking about, which is it is our problem. You know, this is actually something we are responsible for. It is a great privilege to be in the position that we're in. And when we are getting these results, we should be making sure these patients are seen and followed up appropriately. What I'm very keen about is mainstreaming. So actually the surgeon taking the consent for the Lynch syndrome testing. And, you know, this doesn't take much training. It's a very straightforward conversation to have with someone. And what it would just mean is taking a blood test in clinic when you're seeing them, sending that blood test off. They can get definitive Lynch syndrome testing. And then what this means is that a service that's already overwhelmed, like clinical genetics, only needs to see those patients who have Lynch syndrome. They don't need to see those that don't have it. So it takes out the genetic counselling step, and it's what we use in ovarian cancer for BRCA testing, and the medical oncologists have adopted this excellently. So I think we should be doing this in surgery as well. The take home then, just to go over these things, is that the mismatch repair testing saves lives. It does it in two ways. One, it identifies those with Lynch syndrome. It means that their family members can be screened and then they can be enrolled in risk reducing strategies to ensure that they don't go on to develop a cancer. And also we know that the mismatch repair testing is a biomarker for potential response to immunotherapy as well. I think surgeons should be leading this journey and they should be responsible for it. And I think we should all be trying to work towards mainstreaming. And one of the things I think is really exciting at the moment is that there's a trial going on led by Professor Ranjit Manchanda in Barts called the DETECT2 study. We've taken part in that in Edinburgh. I'd encourage you guys in NHS Grampian to look into it as well, which means that we are now involved in mainstreaming in a study which feels very supported and very helpful. And it means that we are starting to learn those skills with the support that we wouldn't otherwise get. So, bit about what we do as gynecologists with Lynch syndrome. Surveillance. Well, surveillance is controversial. We don't know if it works. There's not good data supporting its use. We do it here in Edinburgh. Lots of centres do it because it feels like it's the correct thing to do. The guidelines across the world all disagree about what follow-up we should be doing for these women. These are healthy people with Lynch syndrome before they get an endometrial cancer. Should we be doing biopsies? Should we be doing ultrasound? How regularly should we do them? Well, no one can agree. And we are about to launch a study. So this is a shameless pitch for the PREDI-Lynch study, which is going to be run by Edinburgh, but we want everybody to be involved. I think it's a really exciting opportunity where we will set up Lynch syndrome clinics and we will run Lynch syndrome surveillance, and it will again be within a study, so nice and safe, lots of support. And we will see whether or not using routine methods for surveillance versus symptom surveillance versus liquid biopsy surveillance, which one of those work, which one's non-inferior, how it all pans out. So I'd really encourage you guys in Grampian, if you're interested, to reach out to me, and I'd love you to be a site that we could recruit from. Okay, thank you ever so much for this opportunity. It really is amazing. I think we are lucky in Scotland. We are a small family, and we're a very close family, and I think that it's one of those things where it's great to be able to like come up and see you guys. It's great we can have you down, and we all work together in such a collegiate way. So thank you very much for inviting me to talk today. That's my email if you want to contact me about anything. Just it's neil.ryan@ed.ac.uk. So neil.ryan@ed.ac.uk. Thanks ever so much. Thank you.
So if you don't mind, Neil, can I ask a question? Do you think that all pathologists in Scotland are testing for Lynch and the results then do go to MDT? So why is MDT not making that decision to inform? Often they say just patient-initiated follow-up. Do you not think that the MDTs should then say that please refer your patient for genetic testing for Lynch syndrome?
So I think they do. I think the problem is this diffusion of responsibility. I think that what happens is it goes out. I see this in my MDT all the time. Oh, patient needs referral to genetics, and it's like, well, okay, but who's going to do that? And the problem is that you've got the person who took the Papel biopsy, who's often one of our general colleagues. Are they referring to clinical genetics? Is it us referring to clinical genetics? Is it the oncologist referring? So who is it? The pathologist? Like who refers to clinical genetics? So I think it's really important for when that is said, that someone says, I will do that. And then it's assigned to them as a task. Because if it's not, then what happens is that it's said, and we document it, it's in the MDT record, but no one does it because everyone goes, well, it's that person's problem. Then we see that in our MDT. And so I am often there like, I'll do it, because otherwise it sort of vanishes off into the ether.
I mean, for such things, I would imagine that there should be well-established pathways, just like there is for BRCA gene. There is a way of doing it, because if you might have heard that story of somebody thought anybody could do it, but nobody did it. And that means that people are missing out on the opportunity for early detection. Obviously, detection itself is not enough for the relatives because we don't have a pathway of what to do next either. So there's a lot of work to be done. And whether it should be taken up more with the guidelines committee, that, how the responsibility is shared, whether it's between the surgeon, MDT, GP, something similar to, I would say, what we do for BRCA genes.
So all the pathways are there. that's the bit that's really like, it's all there. It's just that no one makes the referral. That's the bit that's funny about it. Well, funny or tragic about it, I guess, is that everything, we've got the pathologists do their job. They do the testing. The clinical geneticists are all sat there ready to do their bit. We're sat in the middle and we're the weakest link. So we just go, oh, refer to clinical genetics. And as long as someone does that, it will all work, but someone has to make the referral.
But I suppose it would be with the person who is going to, who's operated on the patient. I would have thought so, because normally that's how it works.
You can either have someone named, so the way that we've done it is that I'm the person that makes the referrals. So
I'm not even sure who does it in Grampian. And interestingly, I've never even had a report saying, if it's not common, that this patient needs genetic referral. But I'm sure it must be done, and there might be a pathway.
So, I mean, the other thing to do is actually the name surgeon, like you said. So, there'll always be a name surgeon on that patient, and it's their responsibility to refer. And so what we've started to do in our MDT outcome is it now says referral to genetics and then the name of the person who will make that. And then
who's responsible for the task to be actioned. Okay, well, that's interesting. Any other questions for Neil?
So I can read the question, which is, do you have any regional data regarding referral rates? I do.
I've been allowed in. Yes, Neil. Hi there. How are you? Thank you for the talk. Yeah, sorry, I didn't know if that was preventing questions. Yes, that's the question. I mean, I'm just thinking that the NDT systems do vary across the UK and across Scotland. Yeah.
So we definitely do, Dr. Milling-Smith. So we can see that Scotland does particularly badly, and we can get down to the granularity of the cancer centre. We don't know about what's going on in the units because the audits was undertaken in the centres. So I think across the board in Scotland we were doing badly in referrals, worse than our colleagues in England. And I think the problem, there was two artifacts within that. One was that a lot of so Manchester was doing very well because obviously it was the centre that sort of did the first study, so they had already set all these things up. And then the other artifact was that NHS England had just started this Lynch syndrome project, and so there was a lot of noise about it, and education and centres in England were very much aware of what they needed to be doing. And I think that that's something that's quite difficult in Scotland, is that we don't have like an NHS England body to sort of go, right, give us a load of money to make this, national problem better. And it's very much health board driven. And so this is quite low down on a health board's priority with everything that's going on. And so we are still, I looked at recent data as well, we are still underperforming compared to England. And, what the advantage in Scotland is that there's only 3 centres. So we can sort this without needing a big national project and all of that stuff. We can just do it by implementing what has occurred in England without all of the training and research and development that needs to go into it, because we've got those lessons. We say, right, let's adopt this across our 3 centres. So that's something we just need to sort out, really.
Yeah, I'd say just because obviously we participate in the West, and they have this new MDT platform. I don't know if you've seen it, and so everything's uploaded and it's a big database. It's a really powerful piece of equipment. I actually have no idea what our referral rates are like for MMR, but what we don't ask is, we could easily put a drop-down box, MMR positive, yes or no, and then that would automate a onward kind of action. But that'd be something to ask the captains of the platform, Arona and Kevin in the Glasgow. But it may be something to look at. And
that platform sounds very exciting.
It's quite cool. It's quite cool. It's worth having a peek at or something. Yeah.
Amazing. Okay, I'll try and that's what, before the improvement, when I was in Bristol, one of the things that we did as well was we had a set form, and on that form it said MMR result needs referral to genetics, who's doing it.
Yeah, so that would, really so we all use the same platform, so you would just put that exact thing in. It's yeah. Thank you.
Nice to hear from you.
Thank you. Have we got any more questions?
No, Lucky, I don't see any hands raised or any questions in the chat.
Thank you. So thank you again, Neil. And I think there's definitely scope for improvement in Scotland, and hopefully you can be leading the way because you're so invested in it.
No pressure.
But yeah, what Ollie suggested sounds great to me. I mean, if there are only 3 centres, everything goes through MDT. So it's about streamlining the pathways. So thank you again. I would now like to introduce our second speaker, Sarah Kennedy. So Sarah joined NHS Research Scotland in April this year to facilitate and support the delivery of VPAG investment. And like me, many of you might be wondering what VPAG is. So VPAG is actually a voluntary scheme for branded medicines, pricing, access, and growth. And Sarah will surely tell you all about it. She has more than 15 years of experience in research and development, and prior to this, her role was based in NHS Tayside as a portfolio manager, where she was responsible for 6 NRS specialty areas. So Sarah, the floor is all yours. So if you can tell us a little bit more about VPAG, that would be great.
Thank you so much for that introduction. And I'm just checking if everybody can see the slides that I'm sharing okay?
Yes, Sarah.
Yes, we
all
can.
good.
Thank you.
Perfect. So thank you again for inviting me to come and speak at this meeting today. As Lucky said, I'm going to just provide a short overview of the VPAG programme in Scotland. So as I said, the VPAG stands for the Voluntary Scheme for Branded Medicine, Pricing, Access and Growth. And that's really the agreement that we have between the pharmaceutical industry and the UK government for what the NHS will pay for branded medicines. For this current 5 years that we're in of the scheme, there's been an agreement reached to reinvest a proportion of the profits of that scheme back into the NHS through this investment programme. And that investment is going to be in 3 specific areas. So there's a proportion that goes towards sustainable manufacturing, a proportion that goes towards modernising HTA, and the bit that we're that the rest of this discussion is going to be on is around that clinical trials proportion. So investing in infrastructure to expand the capacity and capability to support commercial clinical trials activity within the UK. It's a 5-year investment and UK-wide it's almost 400 million. So the investment in Scotland over 5 years is close to 40 million. In Scotland, the bid that we submitted to the investment fund was for our Catalyst bid. Catalyst stands for Collaborative Accelerator for Commercial Clinical Trial Delivery in Scotland. And what we've decided to do in Scotland, which is slightly different to how the English fund has been used, is really to build on the existing nodal NHS Research Scotland infrastructure, which is summarised on these slides here. As I said, we're building on this infrastructure, and as part of our Catalyst proposal, we're setting up 4 Scottish commercial research delivery centres, and these will operate on this kind of local, regional and national model, also with this focus on community care. This increased investment will also support increased dedicated and trained staff with protected time, which will increase the number of research-ready investigators to be able to support our research activity. There is also myself and my colleague Catherine are part of our central management team, and we're also there to support some of those kind of feasibility assessment and that kind of national coordination of our scheme activities. There are 4 Scottish commercial research delivery centres have been established now. The VPAG funding came to us, and this is in April of this year, and this is our kind of first year of activity. So these, as I said, have been established to align with 4 existing Scottish clinical research facilities. So we have CRDCs in Edinburgh, in Glasgow, in Grampian and in Tayside. And we've increased our capacity through the creation of additional clinical space, which will support our capacity for additional clinical research visits. We also have additional staffing resource within these facilities. So, for example, additional research nurses, data managers, additional administrative support, clinical research fellows, additional sessional time for consultant sessions, as well as support department staffing and infrastructure. So, for example, pharmacy, radiology and ophthalmology. And as I said, this capacity and infrastructure is there to support the commercial clinical trial portfolio in Scotland, which obviously includes reproductive health and childbirth studies. The exact allocation of resource and support for each individual study or each portfolio will be determined at that local CRDC level. So that's what we've achieved so far within our we're still within our first year activity. The next steps for our Catalyst proposal is the kind of the development and launch of our CRDC spokes. These spokes will be funded from April 2026. We're going to have primary care spokes based in Lothian. These will be our practice embedded research units, and there will be 2 to 3 practice embedded research units that will be launched across Scotland. We'll also have 3 secondary care spokes that will be funded from April. These are Lanarkshire, Highland and NHS 5. We'll also be continuing with some of our horizon scanning activity. We've been undertaking a lot of industry engagement with a number of commercial companies to understand their upcoming commercial pipelines and to better plan for delivery of those studies when those pipelines come to fruition. Within our VPAG Investment Programme within Scotland, we also want to support novel models of trial delivery with this investment. And as such, we've been doing a lot of work around potential models for hub and spoke or multi-location delivery. So there's been a hub and spoke short life working group, which has engaged stakeholders across the UK and has delivered some interim findings around the way that we set up to be able to deliver hub and spoke commercial trials, really with that aim to increase engagement, increase our ability to deliver recruitment, but also focus on better serving our communities and being able to reach those patient groups that are traditionally underrepresented. So as well as what we're doing in Scotland with our 4 CRDCs and our spokes coming on next financial year, our CRDCs are also part of the CRDC UK network. The CRDC UK network was formally launched on the 1st of September following a successful federated bid across all of the CRDCs. There are 15 CRDCs in England which are funded and supported by the National Institute for Health and Care Research. And a number of these have been transferred from the former patient recruitment centres. In Scotland, as you know, we have 4 CRDCs. There's 1 CRDC in Northern Ireland and 1 CRDC in Wales. From January, there are also 14 new primary care CRDCs, which are going to be based in England. The network's led by Melanie Davies from Leicester. And we have co-directorship for the Devolved Nations from Chloe Cowan, who's based in Glasgow. And the senior management team listed here will be supported by an operational director who's due to start in January. And within the activities of the network, there are 9 different work streams. So the focus on strategic collaboration, industry engagement, cross-CRDC coordination, data activity and performance, skills, training and workforce development, and also operational services. We also have a patient public involvement group, a research inclusion group, and marketing, communication and events. These themes are supported by programme managers, which are currently in the appointment process. Of these 9 work streams, Scotland are co-leading 4. So the data activity and performance work stream and the operational services work stream are co-led by Jessie Dawson in Glasgow. And the inclusion work stream and workforce work stream are co-led by Professor Vassan in Grampian. So this is a UK-wide network to support and deliver against the aims of the VPAG scheme. So what we're actually looking to deliver as part of the scheme, obviously the overarching aim to increase capacity for commercial clinical trials within the UK, but there are a number of specific performance metrics that will be measured on. So those are an increase in the number of trials that were supported, as well as specific aspects of trial performance. So looking at the recruitment per year and making sure that we're delivering our recruitment to time and target. And then also time to set up studies, with a big focus on this 150-day target from IRAS submission and to the first patient, first visit, as well as further metrics that are going to be built in around access and inclusion. And again, as I said, all commercial activity in Scotland will form part of our VPAG performance metrics. So again, that includes commercial studies that are on the reproductive health and childbirth portfolio. So I just, in the last couple of minutes of the presentation, I just wanted to highlight how the reproductive health and childbirth portfolio currently contributes to the metrics. I apologise that this is a little bit small. This shows the commercial recruitment data from 23-24 financial year onwards. So you can see that in recruitment rankings, the reproductive health and childbirth specialty is sitting in 7th, with 255 recruits over those 2.5 financial years. But what's interesting, I think, to note is those 255 recruits come from 9 studies. So when you compare that with the next highest, musculoskeletal, where their 237 recruits come from 35 different studies. I think it's useful to think about whether the VPAG investment scheme provides potential opportunities both to increase the number of studies and then help diversify the portfolio within reproductive health and childbirth. Looking at the feasibilities that we receive, so these are the number of feasibilities where commercial companies approach with studies that we could take part in. We see that we're reproductive health and childbirth is kind of middle of the pack. And then when we look at our responses, we can see that of those 5 that we've had submitted for 2025, they've generated 31 responses from study sites. And 6 of those have been accepted. So what I'd like to kind of leave you with is just to consider what more the VPAG scheme can do for yourself in terms of increasing the activity of the commercial reproductive health and childbirth portfolio. Thank you very much, and I'm happy to take any questions.
Thank you, Sarah. Any questions for Sarah?
I don't see any questions in the chat, Lucky, but if anybody wants to come in, please raise your hand and we can let you in as well.
I think, Sarah, you've stunned everybody in silence, but if you don't mind, I can ask you a question. So
Sure.
there are lots of, expression of interest questionnaires we get from commercial studies. But because they can be quite demanding, one of the reasons why clinicians struggle to support them is lack of time, and there is not usually provision of extra time, or they can't cut a clinical activity to do that. So how is the network supporting that?
Yep. So there are, I suppose, a couple of ways. So each R&D department will have resources that support that feasibility process locally. So there may be staff within the local R&D departments, both in the kind of facilitators role, but also potentially within your CRFs that can help to support that information. There's also recently been a new site ID service launched nationally. So it's a national system that Scotland are trying to gain access to. That will automate a lot more of that functionality, and again should streamline that process.
So will the R&D help in finding extra time for clinicians? Is that what you're saying, Sarah?
So both. So the R&D facilitators can potentially take some of the burden away in terms of completing that paperwork for you. If there are often there are kind of almost standard questions that are asked every time that we can kind of pre-agree some text to fill that in. But yes, also as part of VPAG, there is sessional time built in within each of the CRDCs that's been allocated to the health boards hosting those CRDCs. So that would be a discussion with your PIs and that local health board to build a case for sessional time for your investigators. But yes, the funding is there, but it's at the, I guess, discretion of those R&D directors around who specifically is allocated that sessional time.
Yeah, and I think that would certainly make it easier, because one of the reasons why we decline many studies is due to lack of time, obviously, and there's the commercial studies are far more demanding than the non-commercial trials. So I mainly have the non-commercial trials, but we did one commercial one as well, and we could have a research fellow for that to do all the work. But a lot of work sits with the clinician, not just the paperwork, which research nurses are absolutely great at doing, but sometimes they need review appointments with clinicians, certain examinations, and lots of stuff. But I think it is way forward, as you're saying, that you're also including primary care as well, and hopefully, if there's more of an appetite, people can get more time to participate in this research as well. I think we've only got a minute left. Has anybody got any other question for Sarah? Well, if not, then thank you very much, Sarah. And I would also like to remind everybody that we will continue with these quarterly webinar series, and Annie will keep everybody posted through emails. I think the next one is in February and then in June. Annie has also shared the list of events that are going to happen within the reproductive health network. So if anybody has any questions, please do get in touch with Annie. I'm sure you all have her email address, but we could certainly put it in the chat as well. Thank you very much, and lovely to see you all. And thank you to our speakers. Bye.
Thank you.
Thank you, everyone.